Okay, next topic is chest trauma, and we're going to start off with rib fractures. Rib fractures for test purposes, we got to remember the elderly patient that gets the rib fractures. Now, what kind of elderly patient can be predisposed to rib fractures? Osteoporotic patients, right? But other patients that can get rib fractures are elite athletes. It can happen secondary to cancer. It can happen secondary to infection. So, how are these patients going to present? They're going to present with pain with breathing or pain on movement. And a lot of times you're going to get a grating noise that's going to happen on movement or on breathing. And what we have to be wary of is the elderly patients. Because in elderly patients, the progression of pain can lead to hypoventilation, which can lead to atelectasis and ultimately lead to pneumonia. So we have to treat elderly patients with intercostal nerve block. And young patients, we're simply going to observe them and give them analgesics slash painkillers. Okay? Next topic is traumatic rupture of the trachea or bronchus. What do we want to remember in traumatic rupture of the trachea or bronchus? Pneumomediastinum. And that's subcutaneous emphysema in the upper chest and the lower neck. And this is usually going to happen after a high-speed car accident on the test. And the chest x-ray is actually going to show air in the tissues. And how are we going to identify the lesion and secure the airway beyond the lesion? We're going to actually do a fiber optic bronchoscopy. This is how we are going to identify the lesion, and this is how we're going to secure the airway beyond the lesion. And we're going to repair them with surgical repair. Next question, flail chest. Flail chest is a high yield topic on the exam, and it actually occurs with multiple rib fractures, and you get something called paradoxical breathing. And what paradoxical breathing means is that on inspiration the chest wall is actually going to cave in, and on expiration it's actually going to bulge out. Okay, and that's called paradoxical breathing. But what we have to remember on flail chest, our underlying problem is actually the pulmonary contusion that occurs. Now, what we want to remember is that the contused lung here on flail chest, that's our underlying problem, is very sensitive to fluid overload, okay? So our first line treatment is actually fluid restriction. And after we do fluid restriction, what are we going to do? We're going to use colloids, okay? And what are our colloids? Either plasma or albumin, okay? We're not going to use crystalloids such as regular IV fluids. We're going to use colloids, okay? And we're going to use diuretics. So how are we going to treat flail chest? First of all, how are we going to recognize it? We're going to recognize it, a patient that comes in with multiple rib fractures with this paradoxical breathing. That means on inspiration, the chest wall is going to cave in, and on expiration, it's going to bulge out. And our underlying problem we've got to worry about is the pulmonary contusion, which we're going to go into in a second. And we're going to restrict fluid, and we're going to use diuretics, and because the contused lung is very sensitive to fluid overload, we're going to actually use colloids, such as plasma, and we are going to avoid using crystalloids, such as regular IV fluid. Our next topic is pulmonary contusion. This is really easy to recognize on the test because the chest x-ray, if they show us a CXR, it's actually going to show a white out appearance, okay? And this is going to happen secondary to chest trauma, just like myocardial contusion. But what do I want you to look for? I want you to look for white out on the chest x-ray. And it can appear a lot of times 48 hours later, so we have to monitor these patients, okay? A lot of times this is the hidden injury, and the treatment is the same thing as it is for flail chest. So it's pretty easy to remember the treatment of pulmonary contusion because it's the same thing right here as we did for flail chest. Fluid restriction, colloids rather than crystalloids, diuretics, and we're going to monitor and intubate these patients with PEEP. And it makes sense because we said, what is our underlying problem we got to watch out for in flail chest? The pulmonary contusion, right? So remember, it can be a hidden injury, and it's going to present as white out on the chest x-ray, and up to 50% are asymptomatic. Next topic, myocardial contusion. This is another gimme. Like I said, pulmonary contusion is going to happen after a car accident or some type of chest trauma, and you're going to look for this white out, right? and it can be a hidden injury, and we're going to treat it with this fluid restriction, colloids, diuretics, monitor blood gases, intubate patients with PEEP. Myocardial contusion, it's going to happen secondary to a blunt myocardial injury. So it's going to be a bruise of the heart. Remember, these patients can actually show up with a bruised chest, okay? And it's difficult to diagnose. But what do I want you to look for in the stem of the question? I want you to look for a patient that had some type of chest trauma. Usually can come in like after a car accident. And they're going to have these EKG findings, such as V-tach or some type of arrhythmia with the chest trauma, okay, after a blunt chest trauma. So it's going to be EKG findings that are seen after sternal or blunt chest trauma. What do we have to do in these patients? We must monitor the EKG. The EKG is actually going to detect it, right? Because we're going to look for some type of arrhythmia. And we're going to look for our troponins are what's specific. And troponins and EKG should always be ordered anytime we have a sternal fracture, okay? And ST segment changes are our most common finding in myocardial contusion. So what is our treatment? Our treatment's actually going to be focused on the complications. So what are the complications? EKG complications, such as V-tach or any type of arrhythmia. This is what we're going to actually be trying to treat. We're going to treat the underlying arrhythmia, whatever the EKGs find, okay? So all patients should be admitted to the ICU for observation and cardiac monitoring, okay? So our treatment involves whatever our underlying EKG finding shows. So pulmonary contusion, something like a car accident, some type of chest trauma with a whiteout, right? Flail chest, underlying problem is the pulmonary contusion. And myocardial contusion is after blunt abdominal trauma, a bruise on the chest we may see with some type of EKG findings. And our treatment is going to be treating whatever this EKG finding shows. And traumatic rupture of the aorta is pretty high yield because it's a hidden injury, okay? These patients are usually totally asymptomatic. And a common way they ask this is a deceleration injury, such as a fall from a great height or a person being ejected from a car in a motor vehicle crash. Okay? So what we're going to do first, we're going to do a chest x-ray. And based on the chest x-ray, we want to see if there's a widened mediastinum. If there's no widened mediastinum, we're going to go to transesophageal echo or spiral CT. So first step, CXR. We're going to look for a widened mediastinum. No widened mediastinum, transesophageal echo, or spiral CT. If there is a widened mediastinum, we're going straight to aortogram, and we're going to go to surgical repair. So first, on traumatic rupture of the aorta, look for deceleration injuries such as a fall from a great height or patient being ejected from a car in a motor vehicle crash. Chest x-ray, no widened mediastinum, we're going to do transesophageal echo or spiral CT. If it's positive, straight to surgical repair. If there is a widened mediastinum, we're going to go to aortogram, and based on the aortogram, we're going to go to surgical repair. Aortogram can also be indicated if non-invasive studies are inconclusive. And basically, we're going to look for fractures in chest bones that are really hard to break. And that can be a clue on the exam for traumatic rupture of the aorta as well. Okay, so I think we got these down. Rib fracture, remember, look out for the elderly. Elderly patients, we're going to do intercostal nerve block. And the young patients, we're just doing observation analog 6. Traumatic rupture of the aorta, we're going to look for the pneumomediastinum on chest x-ray. We're going to identify with fiber optic bronchoscopy and surgical repair. Flail chest, we're going to look for multiple rib fractures with the paradoxical breathing. We're going to look for the underlying pulmonary contusion, which is a whiteout on the chest x-ray. And we're going to treat with fluid restriction, colloids, which is plasma or albumin, not crystalloids, which is IV fluids, diuretics, and we're going to monitor blood gases and intubate patients with PEEP. Pulmonary contusion, same thing. Fluid restriction, colloids, diuretics, monitor blood gases, and intubate patients with PEEP. Myocardial contusion, chest trauma, it's going to happen secondary to blunt chest trauma, and it's difficult to diagnose, but if we see EKG findings after the blunt chest trauma, we're thinking myocardial contusion, and our main thing we want to do to treat these patients is whatever this EKG finding is, we want to treat that. And traumatic rupture of the aorta, think a fall from a great height, which is commonly asked, or a deceleration injury, such as being ejected from a car in a motor vehicle accident. Look at the chest x-ray. We're going to look for a widened mediastinum. If no widened mediastinum, echo or spiral CT. If a widened mediastinum, aortogram, and if aortogram is positive, we go to surgical repair.